Good morning, all. I am Dr. Nagalingam, Associate Professor, Department of Anesthesiology from Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry. Today, we will see about pain management and how we are going to manage and what all the contents we are going to see. Now, we'll see. Today in this session, at the end of session, all of you should know something about introduction, classification, types of pain, and how to assess the pain and how we are going to treat that pain. Let's see the definition. It's a pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. This is very important. First, we should know the difference between actual and potential tissue damage. It's a kind of whether really the tissue damage is there, or even if it not is there, also patient can feel the pain sensation. That is what here we are going to mean. Pain may not be directly proportional to the amount of tissue injury. It is highly subjective and always leading to under treatment. In clinical scenario, in real life, many patients we can see those who have very high tissue injury, they won't say that much. They won't complain that much pain. But in some scenario, even a small injury, okay, they can't tolerate that much pain. Also, they will cry a lot. They will do lot of. They will show lot of emotional things. This always lead to under treatment. So it's highly subjective, and whenever the patient is complaining pain, we should treat the pain. We should not in the terms of no, this is trauma. It should not go in that way. In cancer patient, the prevalence of pain is in advanced disease is almost 70 to 90%. And whatever you do the pain always it will progress. So that's why the prevalence rate is 70 to 90%. In HIV disease, the pain prevalence is about 50%. In other illnesses may have significant pain, but there is no clear data available right now. Then we'll proceed with the classification. How will you classify? Mainly, we can classify into acute and chronic pain. And chronic pain, again, we can divide it into non-malignant pain and malignant pain. In acute pain, if suppose the patient is suffering from injury, trauma, any spasm, disease to skin, muscle, or somatic structures or viscera, it's acute in onset. Immediately, whenever the injury happens or trauma happens, immediately patient will start feeling the severe pain. That is called acute pain. It is perceived and communicated through the peripheral mechanisms, pathways, usually associated with autonomic responses as well, like tachycardia, increased blood pressure, diaphoresis, pallor, and mydriasis. If the patient is feeling some kind of any kind of tissue damage, like a patient with a road traffic accident or history of fall, this all comes under acute pain category. Whenever the skin, there are a lot of receptors are there over the skin. Okay, whenever the patient hit with any kind of injury, immediately pain signals will transmit from the skin receptors to the brain. Okay, that is what here we are. The pathway meaning is that is the peripheral mechanisms. The pain receptors always it will pass the signals to the spinal cord. From spinal cord, it will reach the brain, and the brain it will the pain center it will activate. Then only patient will feel the pain. Usually, it subsides quickly as pain-producing stimuli decreases. It is associated with anxiety. It can be understood or rationalized as a part of healing process. Then comes to the chronic pain. First, we will see about the non-malignant pain. Pain persists beyond the precipitating injury. That means even though the acute trauma, injury, everything is gone, but what will happen in the skin? Already I told you about the pain receptors. The pain receptors will get it will be in a deregulated condition. Even though without any stimuli, it will keep on send the signals to the spinal cord and it will reach to the brain. And even though if there is no tissue injury also, because of that altered pain neuron endings, the patient always feel the pain. Okay, still I'm feeling pain like that. That is the classic characteristic of chronic pain. It is rarely accompanied by autonomic symptoms. And sufferers often fail to demonstrate objective evidence of underlying pathology. It is a classic sign of characteristics of chronic pain. It is characterized by location visceral, myofascial, or neurological causes. In those are all the cases, you will get the chronic pain. Then coming to the malignant. As you know, everyone, already we discussed also, malignant, it has characteristics of chronic pain as well as symptoms of acute pain, like breakthrough pain. It has a definable cause, some tumor or some origin. You can locate the origin. So that in the treatment also, narcotic habituation is not a concern. In other case, it's not that scenario. Only in cancer patients, this narcotic habituation is not a concern. Then comes to the types of pain. What are the types of pain? We know. Again, it's classified into somatic pain, visceral pain, bony pain, neuropathic, emotional, spiritual pain. First, we will see about the somatic pain. It is often a aching, often constant, maybe dull or sharp pain, often works with the movement, well localized, over the skin, muscle, joint, superficial or deep structures. Example, bone or soft tissue injury or chest wall injury. This kind of pain usually best way you can treat with the NSAIDs. It is a classic. If whenever the trauma occurs, whenever the spasm over the skin, muscle, joint structure occurs, the patient will immediately start feeling that somatic pain. Then coming to visceral pain. The name itself will tell you what is the visceral pain. It is whatever the viscera inside the human body. If suppose some injury or inflammation happens to the viscera, it may be intrinsic causes or extrinsic factors also may be possibility for that visceral pain. It is almost a characteristic of constant or crampy pain. It's aching or burning also. It's poorly localized. Sometimes it can be referred pain also. For example, in diaphragmatic irritation, patient will have the left shoulder pain. So there is a characteristic of referred pain. All of you know about the referred pain, I think so. Then we'll move to the next. What are the organs mainly involved? The mainly organs of thorax and abdominal cavity is mainly involved in visceral pain. It is usually as a result of stretching, infiltration, or the compression, like any kind of tumor or any kind of inflammation or any kind of any ulcerative diseases. Okay, this will lead to the stretching and infiltration and compression of the organs, like in the thorax and the abdominal cavity. For example, liver capsule distension or bowel obstruction, these are all the causes for visceral pain. It's usually, as I told, aching or burning, constant cramping, poorly localized pain. Both somatic and visceral pain travel along the same pathways. Pain stimuli arising from the viscera is perceived as a somatic in origin. This can be confused by the brain, often referred as a referred pain. See, here in this diagram, as we discussed earlier, whenever the injury or trauma happens to the skin, there are pain receptors in the skin, and that will pass signal to the spinal cord, and it will reach to the thalamus area, where the pain will feel the pain. Okay. In visceral pain also, for example, in the myocardium it is there, and this is also same pathway only, patient will feel the pain. Then we'll see about bony pain. Bony pain is often poorly localized, aching, deep, burning, and common with malignancy of breast, lung, prostate, bladder, cervical, renal, colon, stomach, and esophageal cancers. It can lead to pathological fractures. Vertebral metastasis can lead to cord compression. That cord compression, acute treatment, immediately you have to take care of that cord compression. Otherwise, patient will end up with severe pain. There are a lot of treatment modalities are there to treat the bony pain that we will discuss in the later part. So in this bony pain, we should remember these things. It is common with the malignancies and can lead to the fractures. Neuropathic pain. It is caused by mainly disturbance of function or pathological changes in the nerve. It may arise from the lesion or trauma, infection, compression, or tumor invasion. It's described as burning, shooting, or tingling pain. It always does not respond well to the standard analgesics. Then coming to the categories of pain. How will you categorize this pain? It's often classified into, according to pathophysiology, can classify it into nociceptive pain and neuropathic pain. Nociceptive pain mainly stimulus from the somatic and visceral structures. Neuropathic pain mainly stimulus abnormally processed by the nervous system. First, we will see about nociceptive pain. It is caused by invasion and or destruction or pressure on the superficial somatic structures like skin, deep skeletal structures such as bone and muscle, and visceral structures and organs. Types of nociceptives are superficial somatic, deep somatic, and visceral pain. Then coming to neuropathic pain, it is caused by pressure on and or destruction of peripheral, autonomic, or central nervous system structures. Radiation of pain along dermatomal or peripheral nervous distributions, often described as burning and deep aching and associated with the dysesthesia or lacinating pain. In this pain, as we discussed earlier, whether there is no need to be a acute inflammation over here, because all of you should clearly know, even it is mainly because of dearranged neural structures, neuron endings in the skin area or in the peripheral mechanisms. Okay, that signals it will whether pain is there or not. It will keep on process the signal to the spinal cord and it will reach to the thalamus. So always whether the stimulus is there or not, patient will feel always continuous pain. Then we'll see about something of the effects of pain, what it will do actually, how it will affect the patient life and or quality of sympathetic responses, mainly pallor, increased blood pressure, increased pulse, increased respiration, skeletal muscle tension, and diaphoresis. These are all the sympathetic responses you can expect whenever the patient has the effects of pain. Parasympathetic responses. Okay, you can see with many patients presenting with decreased blood pressure due to parasympathetic response and decreased pulse, nausea, vomiting, weakness, pallor, or loss of consciousness. If you treat properly pain, all of the symptoms will go away. How will you assess the pain? This is the most important tool, because when you know when to intervene, what to give, all the treatment modalities depends upon the pain assessment. You can't give very strong dose of analgesics for a small mild pain. So how to assess the pain, that is most important. We can assess by the pain history. What is the site of pain, type of pain, exacerbating and relieving factors, how frequently patient is having pain, and how the quality is affected and impact on daily life. These are all the pain histories you can elicit and you can tell. And other important additional questions you have to be asked: what is the response to past and current analgesic therapy? Any kind of diary or record about the pain. Fears they have about the analgesic should be also noted and clarified. Pain assessment tools we can see like verbal analog scales, visual analog scales, and phase scales. This is the verbal analog factors to be considered in choosing the pain scale. These are all the factors you should consider before selecting the pain scale. The first one is the age of the patient, physical condition of the patient, level of consciousness, mental status, ability to communicate. These are all the factors always you should consider in choosing a pain scale. Numeric pain rating scale. Ask the patient, we have to ask the patient to rate their pain intensity on a scale of 0 to 10. 0 means there is no pain, 10 is the worst pain imaginable. Some patients are unable to do this with only verbal instruction, but maybe also to look at the number scale and point of number that describes the intensity of pain. Here you can see the pain score. You can give to the patient and you can ask the patient to mark the pain. 0 is no pain, 5 is a moderate pain, 10 is the worst possible pain. We have to educate the patient to give a accurate reading of the pain. Wong-Becker faces pain rating scale. This is most commonly used with the young children, sometimes as young as 3 years of age. It works well for many older children and adults as well as for those who speak in a different language. Explain that each face represents a person who may have no pain, some pain, or as much pain as imaginable. Point to the appropriate face and say the appropriate description. This face hurts just a little bit. Ask the patient to choose the face that best matches how she or he feels or how much they hurt. It's 0 to 100. Pain assessment 2. 0 means no pain, mild means 1 and 3, moderate is 4 to 6, and severe pain, and very severe pain is 7 to 9. 10 is the worst pain imaginable. And color pain rating scale. Ask the patient to point the area on the scale that shows that level of pain from white, no pain, to dark red, worst pain possible. Obtain a number corresponding to the area where the patient pointing. Again, this you can see in the scale 0 to 2 is a mild, 3 to 7 is a moderate, 8 to 10 is a strong pain. Severity assessment. McGill pain questionnaire. He made a questionnaire about the severity of pain. You can measure scale from 0 to 5, from none to severe pain. For children or adults who understand numerical relationships. For those, it is the ideal pain criteria. Here is a universal pain assessment tool. It is there. Again, it is 0 to 2 means 0 means no pain. 0 to 2 is a mild pain. 3 to 6 is the moderate pain. And 7 to 10 is a severe pain and worst pain imaginable criteria. How will you treat the pain? This is a very important aspect in pain management. What are the goals of pain management therapy? Our first goal is we should decrease the pain. Patient should feel comfortable. That is our first aim. Then decrease the healthcare utilization. Unnecessarily giving lot of unnecessary drugs for treatment of pain. This all should be avoided. Decrease the shopping for care. Decrease the emergency room visits. Improved functional status. Increase the ability to perform activities of daily living and return to employment. So these are the three main topics you should be always, your goal should be. First one is decrease the pain, decrease the healthcare utilizations, and third one is improved functional status. How will you manage the pain? We can classify it into non-pharmacological treatment and pharmacological treatment. Another type of management also is there. Pharmacological treatment usually it combines with analgesics or adjuvants. Non-pharmacological intervention available right now. Those are exercise, weight reduction, counseling, smoking cessation, massage, relaxation therapy, heat and cold applications. And yoga also plays a major role. Yoga, music therapy, these are the non-pharmacological interventions about the pain. Okay, how exercise will improve the pain management? Because whenever, as we discussed earlier, lot of causes are there for pain. Those mainly are any spasm, trauma, or everything. If you do proper exercise and physiotherapy, the automatically pain intensity will come down. And weight reduction. So whatever the weight, if you reduce, no, automatically because body weight will feel lighter and you will feel energetic. The mobility is too good in weight reduction. In that case, obviously the pain will go in the lower side. And smoking cessation, massage, relaxation therapy, everything as already we discussed. Heat and cold applications plays a major role with the blood vessels and with the chemicals, some pain chemicals also that will lead to that plays a major role in pain management. Then it comes to analgesics. What are all the analgesics? All of you know. First one is non-opioids, opioids, and adjuvants. Non-opioids mainly NSAIDs, like paracetamol, diclofenac. Then in that, lot of drugs are become like COX-2 inhibitors. This all comes under non-opioid analgesics. Then opioid analgesics. Opioid analgesics, again, lot of classifications are there. Most commonly used drugs are codeine, morphine, fentanyl, tramadol. These are all the most common used opioids in the pain management. And along with the pain management, adjuvants also plays a major role. Though like muscle relaxants, antidepressant, anti-epileptic drugs, all these things plays a major role in controlling the pain management. Choosing the appropriate analgesics. Match the severity of pain to the strength of the analgesic. For example, strong analgesics for severe pain. WHO has developed a three-step model to guide analgesic choice depending on the severity of the patient pain. In this, you can see WHO pain management ladder. The step 1 is the NSAIDs plus or minus adjuvants. Step 2 is the NSAIDs, mild opioids with or without adjuvants. Step 3 is a strong opioids, NSAIDs with or without adjuvants. And obviously, step 1 is for mild pain. Step 2 is for moderate pain. Step 3 is for severe pain. And in step 4 also nowadays it's available. Here nerve blocks and whatever the needle techniques, it will play major role in the step 4. That is the last step. This is the universally accepted WHO pain ladder scale. Currently, most of the countries they are using this pain management ladder only. Analgesics, non-opioids. There are three type of non-opioid analgesics are there. One is salicylates, the other one is NSAIDs, that is called the non-steroidal anti-inflammatory drugs, and the last one is acetaminophen. Used in full doses for the most of the pain scenarios, all have a ceiling effect to their analgesia, a maximum dose past which no further analgesia can be expected. COX-2 inhibitors may be associated with fewer side effects. Use cytoprotection with NSAIDs only in patients who have symptoms suggestive of GI distress or who are at high risk of ulcer formation. For cytoprotection, use sucralfate or misoprostol. Analgesics. Useful drugs are codeine combination products, oxycodone combination products. Do not use dextropropoxyphene. This is called the weak opioids. Then how will you treat the strong opioids? Useful drugs are morphine, hydromorphine, fentanyl, oxycodone, and methadone. Do not use mepridine, amiloride, and pentazocine. Opioid analgesics is most effective when titrated to the effect. Effective doses highly variable between patients. Standard doses may be insufficient. When used properly for analgesia, addiction occurs in less than 1% of the patients. What are all the opioid side effects? Because opioids is the most commonly used drug for the pain management, and you should know, everyone should know about what are all the effects it will cause. The most common side effects are constipation, nausea, vomiting, urinary retention, itch, rash, dry mouth, respiratory depression, neurotoxicity, and drug interactions. In constipation, it's need proactive laxative uses. It will avoid the constipation. Nausea, vomiting, always consider treating with a dopamine antagonist or prokinetics like metoclopramide, domperidone, prochlormazine, and haloperidol. Itch or rash. It's worse in the children may need low-dose naloxone infusion, may try antihistaminics, however, not a great success. Dry mouth, respiratory depression, and uncommon when treated with response to the symptom. Neurotoxicity mainly are delirium, myoclonus, and seizures. Adjuvant analgesics, otherwise also called co-analgesics. These are all the medications that, when added to the primary analgesics, further improve pain control. May themselves also be primary analgesics. Example, tricyclic antidepressant medications for post-herpetic neuralgia. They can be added into the pain management plan at any step in the WHO ladder. Adjuvants to the neuropathic pain. When pain is neuropathic, there is a good evidence of treating with the adjuvant medication rapidly. Always remember the potential of using radiotherapy, chemotherapy, and surgery as adjuvant modalities with neuropathic pain. May they should not be replaced with any other drug alternatives completely. An adequate trial of 2 to 4 weeks at a full dosages should be tried at each drug. Adjuvants, what are the adjuvants available right now for neuropathic pain? There are three types are there. First one is cyclic antidepressants, second one is anticonvulsants, the third one is local anesthetics. Cyclic antidepressants, the examples are amitriptyline, desipramine, nortriptyline, mamotryptyline. And anticonvulsants are carbamazepine, valproic acid, and gabapentin. Local analgesics are mexiletine and lidocaine. What are the other modalities available for the pain? Nerve blocks, epidural blocks, and ablative neurosurgical procedures may be effective in pain management. Such procedures may be associated with the return of pain after a number of months, so the timing of procedures may be important. Here, before I want to discuss something about the nerve blocks. Before I'm finishing, just I will take 2-3 minutes extra for your people time. And I want to make it clear how nerve blocks works in pain management. Suppose, for example, if the patient is complaining of, first we have to find out what is the cause of the pain, what is the reason of the pain. Any kind of pain, if the, like for example, acute or chronic pain. If the, for example, if I have injury in my little finger always is keep on sending signal to the spinal cord, and it will reach to the brain, thalamus area, where the pain is processing, and always I'm feeling the pain, whether I met with the acute pain or with the chronic pain. First, initially, you can go with the tablets, as we discussed, NSAIDs. Okay. If it is not working out according to the WHO ladder, we have to go to the next stage, and still it is not working out, then we can go for nerve blocks. See, if suppose little finger, there are many types of nerve blocks available for this little finger. Whenever the nerve block you are doing, it is not a permanent one, because we are injecting some chemical in to block the pain sensation to the spinal cord. That is a temporary. Sometimes many people will use steroid also. Steroids, it may act up to 6 months or many years also, I have seen in my clinical practice. By the time we have to strengthen the area, like my little finger is affected, just I'm blocking through the nerves, like digital blocks or wrist block or axillary block or supraclavicular block, any kind of block, or stellate ganglion block also, any kind of block I can put and I can block the pain sensation. By the time I have to improve I have to strengthen my little finger, I have to regain the strength, and automatically after some time when the drug effect goes down, our normal physical strength will come, it will be in the upper side, and that time we can manage the pain confidently. In the end of the treatment, spinal cord stimulators also available that I have not mentioned in this slide. That is the most advanced treatment right now available right now for pain management. In case of any chronic pain, long-standing pain, these spinal cord stimulators can be tried to ablate the pain. And lot of ablative neurosurgical procedures also is there to ablate the pain. There are chemical neurolysis also is there, like with alcohol, with the ganglion blocks also we can do. And ablation procedures also, like also can be done possible to achieve the best pain management. This kind of such procedures associated with return of pain after a number of months. So the timing of procedures may be important. These are all the things already we discussed. Thank you for listening. Thank you for this opportunity to share my experience. Thank you.